Hello, and welcome to the Hope Coalition Chempack training for EMS and hospitals. To successfully complete this training, you will need to watch the video and take a quiz related to the content. There are 5 modules that we will cover in this presentation. Module 1, Chempack Introduction. Module 2, Types of Nerve Agents. Module 3, Physiological Effects of Nerve Agents. Module 4, Antidotes and Treatment Protocols. And Module 5, Notification and Activation Procedures. Welcome to Module 1, Chempack Introduction. Our objectives for Module 1 include the following. At the end of this module, you will be able to describe the purpose of the Chempack program, explain where Chempack program containers are stored in the region, and list at least 3 stakeholders in the Chempack program. Overview of the Chempack program. The Chempack program was initiated in 2003 to enhance emergency preparedness against chemical threats. To reduce response times and increase survivability during chemical emergencies, antidotes and medical supplies are readily available in pre-positioned caches. There are 1,900 caches strategically placed throughout the United States, and these caches are housed primarily at hospitals and EMS facilities. Pre-positioning and storage of Chempack containers. 2 hospitals in our region have caches stored in alarmed cages in a secured room. The EMS cache is primarily made up of auto-injectors with enough to treat 454 patients. The hospital cache is made up of multi-dose vials with enough to treat 1,000 patients. There are federal, state, and local stakeholders for the Chempack program. Federal stakeholders lead the Chempack program, setting national policies and guidelines, while also procuring, maintaining, and replacing supplies in the Chempack containers. Additionally, federal stakeholders provide training and guidance to support state and local partners. Finally, federal stakeholders ensure readiness by training container locations, conducting periodic reviews, and responding to deployment needs. State stakeholders collaborate with the CDC at the federal level to determine optimal container placement and ensure alignment with state emergency response plans. Additionally, state-level stakeholders train state agencies and local responders on the state Chempack plan, deployment, and emergency response protocols. Finally, state stakeholders assist in inspections, inventory checks, and operational coordination for program sustainment. Local stakeholders secure and maintain Chempack containers, integrate Chempack resources into local emergency response plan, and ensure responders are trained to access and deploy antidotes effectively. Finally, state stakeholders lead initial response efforts using Chempack resources during a chemical incident, coordinating with state and federal partners as needed. Welcome to Module 2, Types of Nerve Agents. Our objectives for Module 2 include the following. At the end of this module, you will be able to describe types of common nerve agents, explain the difference between lethal dose and lethal concentration, describe what organophosphate-based agents are, and describe what carbamate-based agents are. Common nerve agents. Chemical warfare agents are used by militaries to kill or maim their enemies. Industrial chemicals are used in agriculture and industrial industries. The list for both chemical warfare agents and industrial chemicals that you see in this presentation are not exhaustive and reflect just the more commonly used. Industrial chemical toxicity. Lethal dose, abbreviated capital L, capital D, is used to classify the toxicity of a substance. For example, a substance with an LD50 of less than 5 milligrams per kilogram is considered extremely toxic, while a substance with an LD50 of 5 to 50 milligrams per kilogram is considered highly toxic. Lethal concentration is a measurement of the concentration of a chemical in the air that kills 50% of test animals within a set amount of time. Using the chart presented with this information shows that lethal dose and lethal concentration for each industrial chemical. Chemical warfare toxicity. Using the chart presented with a lethal dose classifying the toxicity and lethal concentration as a measurement of the concentration of a chemical in the air that kills 50% of test animals within a set amount of time, we can see the effects of chemical warfare toxicity. Common forms of nerve agents. Organophosphate-based agents inhibit the function of acetylcholinesterase in the body. They are best known for their use as pesticides and are commonly used to protect crops or vector control agents to prevent insect-carried diseases. Most military nerve agents fall into the organophosphate class of nerve agents. Carbamate-based agents inhibit the function of acetylcholinesterase in the body. They are commonly used in pesticides, and these pesticides generally are felt to be less toxic than organophosphates. Carbamate-based agents can be found in over-the-counter bug repellents like picaridin. Welcome to Module 3, Physiological Effects of Nerve Agents. Our objectives for Module 3 include the following. List the routes of exposure to nerve agents, recognize the symptoms of nerve agent exposure, and explain the physiological effects of nerve agent exposure. Common routes of exposure to organophosphate-based nerve agents include ingestion, inhalation, and skin contact or absorption from skin contact. Recognize the symptoms of nerve agent exposure. Patients exposed to nerve agents may present with a variety of symptoms. Symptoms may start immediately or be delayed depending on the type of nerve agent and the amount of exposure. An easy way to remember the potential symptoms is the use of the mnemonic SLUDGEM. Our next slide will explain this mnemonic for you. As explained with our previous slide, the mnemonic SLUDGEM is used to remember the potential symptoms of nerve agent exposure. S for salivation, L for lacrimation, meaning tearing, U for urination, D for defecation, G for gastrointestinal distress, E for emesis, meaning vomiting, M for meiosis, meaning pinpoint pupils. Understanding the physiological effects. Nerve agents inhibit the function of acetylcholinesterase. Acetylcholinesterase is responsible for the breakdown of acetylcholine that controls whether muscles relax or contract. If acetylcholine is not broken down, the synapse will continue to fire, causing muscle tissues to become overstimulated, leading to seizures and other major medical issues. Time-critical care. What is aging? Aging is a process where the bond between the nerve agent and acetylcholinesterase undergoes chemical stabilization. Impact. Once aging occurs, acetylcholinesterase cannot be reactivated by antidotes. The damage becomes permanent and irreversible. Timing. This varies by agent, as you can see with the examples of sarin gas and the highly toxic nerve agent VX. Implication. Rapid administration of antidotes is critical to prevent permanent damage. Welcome to Module 4, Antidotes and Treatment Protocols. Our objectives for Module 4 include the following. At the end of this module, you will be able to list the medications in the nerve agent antidote autoinjector, explain how to use the nerve agent antidote autoinjector, explain when and how to use the convulsant antidote for nerve agent, describe the pre-hospital treatment guidelines for nerve agent exposure, and describe the hospital treatment guidelines for nerve agent exposure. Antidotes. Atropine 2.1 milligram. Serves as an anticholinergic agent acting to block the effects of acetylcholine buildup. Works primarily on receptors found in the central and peripheral nervous systems. Pralidoxime, 600 milligrams, commonly known as 2-PAM, which is the name we will be using for this antidote for the rest of this presentation. It's a standard oxime used to reactivate the acetylcholinesterase enzymes, and it works primarily on nicotine receptors in the central nervous system and muscles. Antidote treatment nerve agent autoinjector. The Duodote autoinjector holds 2.1 milligrams of atropine and 600 milligrams of 2-PAM. It has a 4-year shelf life. It's important that the injectors be given into a large muscle area. The most common site of administration is the outer thigh muscle. For thinly built individuals, the injection should be given in the upper outer quadrant of the buttocks. This photo demonstrates the area where the nerve agent antidote autoinjector can be used. The diazepam autoinjector holds 10 milligrams of diazepam. Use of diazepam is for actively seizing patients. Therefore, it is not intended for self-administration. Diazepam should be administered with the 3 antidote treatment nerve agent autoinjector kits when the casualty's condition warrants the use of 3 kits at the same time. Hold the diazepam autoinjector in front of you. Remove the gray safety cap by pulling it out. Do not touch the black end of the injector. Grasp the unit and position the black tip into the victim's injection site, which should be the outer thigh or buttocks. Apply firm, even pressure until the auto-injector pushes the needle into the injection site and it begins firing. Using a jabbing motion may result in improper injection or injury to the muscle. Hold the injector firmly in place for at least 10 seconds. Carefully remove auto-injector from the injection site. Use caution as the needle will be exposed. This slide shows how many antidote treatment nerve agent auto-injectors to use for mild, moderate, and severe exposure to nerve agents depending on the corresponding symptoms present. For example, if your patient has signs of sludgem and agitation, your initial dose in the field would be to observe or use 1 kit. Your repeating dose while transporting to the hospital would be to observe. If your patient has sludgem, agitation, and respiratory distress, that's considered moderate. Your initial dose would be 2 kits, and the repeating dose while transporting to the hospital would be atropine and 2-PAM. If your patient had sludgem, agitation, respiratory distress, and seizures, this would be considered a severe exposure. You would use 3 kits in your initial dose in the field, and then your repeating dose would be atropine, 2-PAM, and diazepam. Note the initial dose in the field by EMS and the repeating dose is done during transport or at the hospital. Treatment guidelines for hospitals. This table shows the guidelines for both adult and children's treatment in the hospital setting. These treatments are based on the effects that the patient is experiencing. They can be mild and moderate or severe. Please note the instructions for additional assistance to contact the Illinois Poison Center at 800-222-1222. This is helpful if the nerve agent is known. Welcome to Module 5, Notification and Activation Process. Our objectives for Module 5 include the following. At the end of this module, you will be able to recognize potential chemical incidents, explain activation of Chempack, list the names of the hospitals to contact for Chempack activation, and describe Chempack deployment logistics. Incident notification, recognizing potential chemical incidents. Here are some examples of possible chemical incidents. However, this is not an exhaustive list. Aerial spraying of public venues during large events, a vehicle spewing a cloud of chemicals driving through a neighborhood, an accident with a tank car on a railway or highway, and incidents involving farming or industrial accidents. Activation. Decision-making process for Chempack activation. 50 or more casualties with symptoms of or exposure to organophosphate nerve agents. If in doubt, request deployment of the Chempack. Chain of command and communication protocols. EMS personnel should contact your resource hospital for medical control and request activation of the Chempack. Resource hospitals should contact the Regional Hospital Coordination Center to formally request the activation of the Chempack. The Regional Hospital Coordination Center will activate the appropriate Chempack host facility and help with coordinating Chempack deployment. The Regional Hospital Coordination Center will also ensure the activation of both Illinois Emergency Management Agency and the Illinois Department of Public Health Emergency Operations Centers. Activation and notifying the Chempack host. Anderson Hospital, 318-391-6480. Memorial Hospital Belleville, 618-257-5289. Springfield Memorial Hospital, 217-788-3000. Announce requesting Chempack activation. Give a description of the suspected agent, number of patients, signs and symptoms, and incident location. Deployment logistics. Transporting Chempack resources. Law enforcement are the primary transport source for Chempack responses. If law enforcement is not available, any emergency vehicle can be used. Coordination with hospital, EMS, and local authorities will be necessary. This completes the Chempack Annex training for EMS and hospitals. Thank you for your time and attention.